I'm Scott Podolsky, and we're again thrilled this spring to host multiple seminars devoted to the health of Indigenous peoples. And for this, we're grateful for the wisdom and input of our colleague, Dr. Joseph Gahn. I'll get to introduce Professor Gahn himself, and he'll have the honor of introducing today's speakers, Drs. Alexandra and Malcolm King. Joseph Gahn is Professor of Global Health and Social Medicine in our department and Professor of Anthropology in the Faculty of Arts and Sciences in Cambridge. He's collaborated for 25 years with American Indian and other Indigenous communities to rethink community-based mental health services and to harness traditional culture and spirituality for advancing Indigenous well-being. He's an enrolled member of the Grovant Tribal Nation of Montana, and among many other roles, is the director of the Harvard University Native American Program. So I'll turn this over to Dr. Gahn.
Thank you, Scott. What a warm welcome, and I want to extend that welcome to all who are joining us today. I'm really excited for today's seminar. As you know, we've been trying to champion a new Indigenous Health Seminar Series here at Harvard Medical School, co-sponsored really between the Harvard University Native American Program, or HUNAP, and the Department of Global Health and Social Medicine. So I'm really pleased that you joined us. As Scott said, I'm a research psychologist. I'm an enrolled member of the Grovant Tribal Nation of Montana, and I'm also the faculty director of HUNAP. It's important that you know that the Harvard Charter of 1650, which governs this university today, actually commits this institution to the, quote, education of English and Indian youth, unquote. And in part, that explains why we have a Harvard University Native American program, really with a fourfold mission. We are committed to education, community, scholarship, and inclusion. And this year in particular, we're really pleased to be celebrating our 50th anniversary. In fact, whether it's been different kinds of programming in the ed school for a while before coming out to the entire institution, there's been 50 years of Native and Indigenous students coming through Harvard in various capacities. And one way we're kicking this off is to found this new Indigenous Health Seminar Series. We had originally conceived this as an in-person seminar series where we would gather for dinner. It would also have a virtual component as well. But obviously COVID has changed our plans in that respect. So we're really glad to be able to do this through Zoom, and in fact, to be able to reach larger numbers of people, even community people from Indigenous settings. So it's been an upside in that respect. So thanks very much to my colleagues and our staff in Global Health and Social Medicine for supporting today's event. I should also say up front that Harvard Medical School stands in the traditional territory of the Massachusett People. What we're going to do today for our seminar is, first, I'll introduce our two speakers today. We're very lucky to have both of them join us. We'll hear from our speakers in terms of their presentations, and then we'll move into audience exchange. And I thank my colleague Scott in advance for helping me to manage the Q&A and exchange portion of this later today. So it's my honor to introduce Drs. Alexandra and Malcolm King. Let me start with Dr. Alexandra King. Alex is a physician and fellow of the Royal College of Physicians of Canada. She holds the Cameco Chair in Indigenous Health and Wellness. She's an assistant professor of general internal medicine at the University of Saskatchewan. She co-chairs the International Group on Indigenous Health Measurement. She taught formally at Simon Fraser University and is a member of the Nipissing First Nation of Ontario. Her areas of expertise include HIV/AIDS, hepatitis C, and co-infections of those diseases. She is an expert in culturally safe and responsive research and care, and tries to advance reconciliation in the Canadian setting and advances two-eyed seeing approaches to scholarship. She promotes shared models of care, especially for remote Indigenous communities in Saskatchewan, and has been a principal investigator on various Canadian Institutes of Health research grants on Indigenous health. Dr. Malcolm King earned a PhD in polymer chemistry from McGill University. He's a fellow of the Canadian Academy of Health Sciences and professor of community health and epidemiology at the University of Saskatchewan. He's the director of the Saskatchewan Center for Patient-Oriented Research. He taught formally at McGill University, the University of Alberta, and Simon Fraser University. And he's a member of the Mississaugas of the Credit First Nation of Ontario. His areas of expertise include respiratory health issues among Indigenous peoples, health service delivery to vulnerable populations, and airborne disease transmission and obstructive lung disease. He's authored over 200 scientific papers, and from 2009 to 2016, he served as the scientific director of the CIHR's Institute of Indigenous Peoples Health. Both Drs. King lead, serve, and contribute to many other national and international Indigenous health initiatives. The title of their talk today is Research with Indigenous People, Ethical Considerations, and Community Engagement. So please join me in welcoming them virtually to Harvard Medical School today. Thank you so much for joining us.
Thank you so much, Dr. Gahn and Dr. Podolsky, for those introductions. I will begin by sharing my screen, and Alexandra and I will essentially take turns with slides. Just one more thing here. Okay, actually, yes, here we are. So you've already given us the title of our talk, Dr. Gahn. So we'd like to begin by acknowledging our territory. We live and work and play in Treaty 6 territory and the homeland of the Métis. That's in the middle of Saskatchewan, and particularly the city of Saskatoon, where the university is located. And we'd also like to acknowledge, as you have, the Massachusett people on whose traditional and ancestral homelands were gathered. The goals of this talk, and I've put down 4 of them, and is understanding the health inequities that currently exist for First Nations, Inuit, and Métis people in Canada. It's a brief, very brief snapshot of history and geopolitics. What are the Indigenous determinants of health? And then what are the ethical principles of engagement with Indigenous people and their communities? And how can engaged ethical research move us forward to achieving wellness? I will start off, though, by situating myself. And this is something that we do as Indigenous peoples in many parts of the world. In the center of this picture are my parents, my late parents, Lloyd and Margaret King. Lloyd lived all his life on our reserve, the Mississaugas of the Credit. My mother, Margaret, came from Switzerland at the end of the war to join him, and she lived the rest of her life there on the reserve. Above them, you have baby Lloyd, some 80 years earlier, with his father and his grandmother on his father's side. And her father is the colorful gentleman who was the last of our traditional chiefs and the first of our elected chiefs in 1870. We have other pictures of family as we go through the generations. We have Alex and myself when we got married some years ago in New Zealand. And then we move on to the next generations. And there's me proudly holding our granddaughter when she was just newborn. And a few months later in the COVID era, when I got to be that close to her, she lives in England with her parents. I'll pass it over to Alexandra now.
Good morning, everybody. My name is Alexandra King. At least that's my government name. The spirit world knows me by 2 names that I've been gifted with. Bapatini Jig, which means moving otter, and Nandiwe Nizaya, which means the healer with a brave heart, standing strong for our people. As Dr. Gahn mentioned, I'm a member of Nipissing First Nation, which is located in Ontario, about 4 hours north of Toronto, and belong to both Eagle and Turtle clans. You see here a picture of my maternal grandparents, and this is where my Indigenous ancestry flows from. So Desmond was an Algonquin Indian from Nipissing First Nation. Mary was Nipissing First Nation, and the baby that they're holding is my mother. And then again, you see our granddaughter on the other side of the screen. And I think for us as Indigenous people, the connection to past and future generations is just so important. And so we are always thinking about whose footsteps that we're walking in, and that we're leading a trail for those who are following us. If you could move on. So this is a drawing of a cartoon of North America, and some of us know it as Turtle Island. There's many other names for this place. But one of the things that I wanted to do was highlight that as Indigenous people, we covered almost all of this territory initially, and that our boundaries were not governed by these nice little neat lines that have subsequently dotted this continent. And so those came afterwards and actually disrupted a lot of familial community nation relationships. And that, as you can see, there's also a lot of overlapping territories. There was some fluidity in how we came to exist over time. But also just, I find that this map really helps to highlight the incredible diversity of Indigenous people in these various territories. This is a map of Canada, and the data that we're showing is the 2016 census, which is the last one that we have on record. What you see in black is the number of people in Canada who self-identified as Indigenous, and that's almost 1.7 million people. In red are the percentage of people who are self-identifying as Indigenous, and in blue you see the non-Indigenous percentages. And so as we look at the map of Canada, you can see that the percentage of Indigenous people tends to vary. In the eastern side, which is where the settlers first came, there are fewer numbers of Indigenous people. As you go through the central area, there are higher absolute numbers, but this is also where the population in Canada is quite dense. And so therefore, as a percentage of the overall population in Quebec and Ontario, Indigenous people make up smaller numbers. When you get to the prairies, which is a little bit further west, what you can see is that the percentage of Indigenous people goes up significantly. So 18%, 16.3%. I want to highlight that these numbers are similar to the number of Maori that are in Aotearoa or New Zealand. On the West Coast, it drops down a bit to 6%. And also when you look up north, what you see is that the numbers of people are fairly small, but the percentage of Indigenous people are high. And so as an example, as high as 86%, 50%, and so on. The other thing that I would like to point out on this slide is that within each province, there are gradients of Indigenous people, if you will, as a density measure. So as an example, Malcolm and I typically live in Saskatchewan, and it's saying 16.3% of the population. The reality is that once you go more than halfway north, the percentage of people who self-identify as Indigenous is much higher, more like 80, 85% even. And when you're down in the south, it is much lower.
So the next few slides will be a very brief history of Canada. And I want to acknowledge Dr. Donald Warren, who talked in this series 4 weeks ago, because he talked about the history of the United States and colonization and how that affected American Indian health, in particular Alaska Native. And the same principles really apply in Canada, but our history is different, and so the context will be different. Canada was never conquered as a territory. It was negotiated. It was negotiated through a series of treaties. And just as in the United States, the colonization of North America took place first from the East Coast and then from the West Coast and gradually moving inland. And the same thing happened in Canada. So you had a series of treaties from the fairly early days, moving westward, and then a certain number from the West Coast. And in the modern era, in the last 50 years or so, we've had a number of treaties in our far north. One of the most important treaties, and I want to focus on it because it's actually something that we share between our two countries, Canada and the US, is the Gashwenta, or the Two-Row Wampum Belt Treaty. And that was made in the very early days of colonization, not between the English, but with the Dutch and the Haudenosaunee, or the Iroquois nations, in what's now New York State. And it consists of purple and white trade beads that signify the European sailboat and the indigenous canoe, with rows of white beads signifying peace, friendship, and forever. And these words that were associated with it: we shall travel down the road of life, never merging with each other. I'm sorry, I don't see my screen perfectly. Anyway, the Gashwenta was a treaty between equals, respecting, where each party respected the other, and it was a treaty respecting the sovereignty, the non-interference between the two groups of people. The later treaties were much different, and in Canada, they're known as the numbered treaties. These took place primarily in the 1870s. So 250 years later than the original Two-Row Wampum Belt. And they were conducted because Canada had just become independent of the United Kingdom in 1867. And the Canadian government needed to have a legal basis for colonization, for selling the land to settlers to come and farm. And that's why the treaties were conducted. But by then, our indigenous population, our First Nations and Métis populations on the prairies were decimated in numbers. They were impoverished, they were starving, and they were not treaties between equals, but far from it. And our peoples were consigned to small reserves, and most of the land went to the European settlers. In one treaty in particular, and I show it partly because where we live, Saskatoon and Saskatchewan, is part of that. Edmonton, Alberta, where I used to live, is also part of the same treaty. The treaty area crosses our provincial boundary, which is an artificial north-south line right through the middle of it. The importance of this treaty, though, is the fact that you have this statement, which I bolded in the middle, that the treaty commissioner promised not only the medicine chest that was the way the treaty was worded, but that this was in addition to what people had already. Our people had a health system, they had medicines, and these were good medicines. And our people who negotiated these treaties recognized that European medicines were also valuable, and they wanted them added to the traditional medicines that we already had. And Dr. Gaughan has already mentioned two-eyed seeing. This is an early example of what we would call two-eyed seeing, recognizing the value of both Western and Indigenous ways of knowing. So we'll go on now, and Alexandra will take over again.
So in Canada, we have the Indian Act, which was brought in 1876 and is still in existence today. And this was an act of Parliament that defined who is and who is not recognized as status Indian. So we apply to the federal government to be considered a status Indian, and they get to decide. This is in contrast to, let's say, how the Maori approach identity, Indigenous identity. And it outlines rules for governing the Indian reserves, and it essentially made us minors under the law, which meant that we couldn't engage a lawyer on our behalf. We were not allowed to vote for the longest while. And we used to have permission to leave the reserve or to return to
Dr. King, I apologize. A couple of audience members were asking if you could speak up a little bit for Alexandra King.
Okay, thank you.
Sure.
You mute.
Okay.
Okay, I'm hoping that this is better. It's probably that we're using one laptop and the mic is further away from me.
Perfect.
So what I was saying is that we have the Indian Act, and it defined who we were and also controlled what we did. And so we used to have permission to leave the reserves and to return. And so in fact, years later, when South Africa was looking at apartheid, they used a lot of the things from the Indian Act and how we structured Canada to come up with apartheid. And they used to have the pass system and other things. But these were things that our ancestors lived with for decades, if not hundreds of years. So previous policies enacted under the Indian Act really resulted in gender discrimination. And so like other Indigenous people throughout the world, we had very rich and diverse understandings of gender. It was not the binary dichotomy that you're seeing that exists within a lot of Western societies of male, female, but rather we had a lot of gender fluid, gender diverse people. And this was recognized within many of our communities as people who had special medicine, special gifts, and they had special roles. The Act also brought in the Indian residential schools, which I will get back to. They banned religious ceremonies, so things like the potlatch, the Sundance, and so on became illegal. There were restrictions on education, as I said, access to counsel, and informed consent. It was the purview of the Indian agent. And so on each of our reserves, we had an Indian agent who really controlled the lives of Indigenous people. I mentioned about the residential schools. And so in Canada, this ran from 1876 to the last one closing in 1996. And really, Indigenous people had no choice but to send their children. They often were arrested if, in fact, they didn't send their children. And as you can see in these photos, the one in the upper area that shows this little boy who was initially dressed in his beautiful regalia. And once he went to the residential schools, they put him in Western attire, cut his hair, and, you know, really transformed at least the external person. You also see all sorts of children pictured in the lower picture as well as the one on the other side. And as time went on, we began to hear so much more about the horrors that occurred at the residential schools. And what I think is also really important to note is that children who ran away were often caught and brought back and punished. And that then when you think about it, your parents went to the school, the expectation was your children would go to the school and then their children in turn. And so this became very much an intergenerational impact on Indigenous people, their families, the communities, as they lost their connections, language, culture. Next slide. Over time, we saw the closure of the residential schools, and in Canada, what we've had instead is First Nations and other Indigenous children being brought into care. And so it started back in the 1960s, and under funding transfer agreements, First Nations children were increasingly placed into foster care under provincial under provincial jurisdiction. And most children who were taken from their homes, what they tried to do was increase the separation. So not only would you be taken from your home, but removed from your community, often transported many miles apart. And often, if there were multiple children in a family, they deliberately broke them up. So you didn't even have your brothers or sisters around you. So this was known as a 60 scoop. And in fact, I have friends and colleagues who were part of the 60 scoop. Some of them were even brought to the United States as well as elsewhere in the world. And they are only now starting to be able to reconnect with family, with siblings, with community. And some of them are not really able to reconnect at all. There just isn't enough information. And so the traumas of disconnection, there's many similarities to those of the residential schools.
So this started to come to the fore relatively recently, and in Canada we have royal commissions to study these things, and this Royal Commission on Aboriginal Peoples was established 5 years before, 1991, after the Oka crisis, when Mohawks from Oka, Quebec, blockaded, and there was a standoff, and this was the result, the establishment of this Royal Commission. I won't go through all the details because there's things that would be familiar to you as well as us: the poor living standards of Indigenous peoples, lower life expectancy, more common illness, a variety of things, violence, alcohol abuse, lack of education, homes, water and sanitation being inadequate, lack of employment, people in the criminal justice system. There were 5 volumes of this, but the important thing really, I think, is in these last statements, that they said that Aboriginal people do not want pity or handouts. They want recognition that these problems are largely the result of their lands, loss of their lands and resources, the destruction of their economies and social institutions, and denial of nationhood. These is the very essence of colonization. And the statement that really stands out to me is that they seek a range of remedies for these injustices, but most of all, they seek control of their lives. And this was more than 20 years ago, 25 years ago, coming up now, that nothing much happened in those 20 years. And one thing that did happen in Canada was yet another Royal Commission. And this was the Truth and Reconciliation Commission that followed the apology for the residential schools by our Prime Minister in our House of Commons. And the commissioners this time decided not to make a series of recommendations, but calls to action, much more forceful. And they covered a variety of areas. There were 94 of them in the end of 2015. It included child welfare, education, language and culture, health and justice. And most of the recommendations were on reconciliation, how to turn things around, how to make things right. But the health ones, I've illustrated 3 on this slide, and there'll be another 2 on the next slide. Is the number 18 is this recognition that the current state of Aboriginal health in Canada is a direct result of previous government policies. And as Alexandra has pointed out, you have the Indian Act, you had the residential schools, the 60 scoops, and other policies. That's resulted in poor health. So that's not enough just to recognize it. Number 19 says we have to do something about it. to set measurable targets and to work collaboratively to achieve them with clear reporting. That's actually something we need our epidemiology community, our scientific community to be involved. And it should really be an ethical obligation. And then number 22 is another statement of this idea of two-eyed seeing, recognizing the value of Aboriginal healing practices and use them in the treatment of Aboriginal patients in collaboration with Aboriginal healers and elders. The last two health ones refer to training of our Aboriginal professionals, support for them, but also cultural competency training for all healthcare professionals. And I would include healthcare research trainees as well, because they need to be part of it. And to require students to take a course dealing with Aboriginal health issues that include residential schools, the United Nations Declaration on the Rights of Indigenous Peoples, and so on. So this brief lecture is really part of what we do frequently in our teaching in Canada. Is we're addressing the call to action number 24. So I'm going to turn it back to Alexandra for further things.
Thank you. So I'm going to talk a little bit about Indigenous health determinants. And what I think is important is, first of all, to start thinking about this from Indigenous worldviews. And that is that as Indigenous people, we do not have a single understanding or perspective on things, but rather that for each of us, there is a critical bond to land and nature. And really, we are part of and interconnected with our landscape. Our knowledge systems come from the land, and the natural environment, in fact, is reflected in not only in our knowledge systems, but also in our social arrangements. So as an example, I am Nipissing, and until fairly recently, in fact, even my maternal grandfather was part of this, we were very much a hunting-gathering kind of society. We also engaged a lot in trade. But if you look at Northern Ontario, we have fairly harsh winters. And so as social arrangements went, in the winter, we would break up into smaller hunting groups, and then in the summers we'd come back together. And so you can see how, in fact, this informed how we organize this society and within families and so on. Our knowledge systems tend to be experiential. And so we really value the wisdom that comes from lived experience. It's observational. Our ancestors watched the world around them and understood what things meant and paid attention to changes. It's very holistic and ecological, systems-based. So we're understanding that, you know, you can't study a plant unto itself, but rather recognize how the environment around it impacts the health and wellness of that plant and how that plant impacts the environment. We have extensive kinships, and often it includes the spirit realm. And, you know, we talk about the spirit world and those within it. And also time doesn't tend to be linear as in the Western understandings, but it's more cyclical and synchronical, which means that, you know, different time periods can even occur at the same time. It can be, I think, understood in a more elastic kind of fashion. So this is a screenshot of an article that Malcolm and I wrote along with Michael Gracie, who was a pediatric gastroenterologist from Australia. And it's called Part 2 because Malcolm and Michael wrote Part 1, which really was a review of epidemiology and the worsened health status, if you will, of Indigenous people. They went back to the Lancet and said that, well, the knowing about the disparities or inequities is really important, and being able to document them is also, quite critical. In fact, one of the things that we felt was even more important was to be looking at the underlying causes of the health gap. And so this is among the first of Indigenous determinants of health that were published in a mainstream journal. If you could go on to the next, thanks. So some of the key messages from this article was the importance of self-determination for Indigenous people. And by this, we're talking about self-determination of the individual, the family, the community, the nation perspective. And I want to harken back to Geswenta, where we had the autonomy of Indigenous people being represented by these two parallel, non-intersecting tracks. And so, and then for us, the Royal Commission on Aboriginal People again brought up the need for self-determination. This has been a long-standing goal and critical to our health. Connections with land, culture, and language. Many of these have been lost for many of us through colonization, including such things as residential schools and foster care. But there were also many of our ancestors who kept these gifts alive. And there are many of us who believe that they are there and sleeping. It's up to us to do the work, do what is necessary to regain the wisdom that our ancestors had. And so these then, the connections with our land, culture, language can be regained through resilient action, through reconciliation in ourselves, as well as with our past. And we're seeing so many wonderful initiatives that have come out since then. The other thing that we covered in this Lancet article, which by the way was published in 2009, which seems now like forever ago, but recognizing that being Indigenous is a health determinant, but it's not necessarily a negative one. In fact, being Indigenous should be a protective thing. We have our culture, our language, our worldview, our medicines, and other things that really are very positive and should help change our health status from one that is disproportionately worse to one that is disproportionately better. And when we look at Indigenous people throughout the world, as an example, we look at our Sami relatives in Finland and Norway and so on, and their health status is actually better than the non-Indigenous population. So this gives us aspirations as to where we can be moving towards. This next slide, again, is talking about Indigenous determinants of health. And so I've just sort of broken it up a little bit differently. So on the one side, we're seeing conventional determinants of health. And these are things like they talk about the WHO, the Ottawa Charter. So how our health is determined by our income, our social status, but also the stratification within society. Poverty, education, employment, and genetics to a lesser extent. And so these things determine not only our health as Indigenous people, but all people's health, and we recognize that. On the other side, though, are things that we consider Indigenous specific determinants of health, or determinants of health that may have an Indigenous specific impact. And so such things as colonization, the connection to land and country, self-determination, were things that we considered to be Indigenous specific. Whereas when you think about some of these other forces, such as globalization, they may have had Indigenous specific impact here in Canada, in the US, or elsewhere in the world. Gender is an example. We, as I said, had different understandings of gender. And so therefore, when colonization enforced a Western understanding, there are then Indigenous specific impacts to this. And that's what we experience both at the individual level, but also at the community level. So this is another way that we look at determinants of health. Another article that came out in 2009 was written by Charlotte Lopi and Fred Ween. And they're talking about Indigenous determinants of health, but take more of a layering approach. And so you have the most proximal things such as, addiction, cardiovascular disease, type 2 diabetes, and so on. And these tend to be the things that people focus on. They're the most visible. They attract a lot of resources within our healthcare system. But if you step back a bit, then you come to the less proximal health determinants. And these are things like health behaviors, employment and income, food security, and so on. So these are actually things that will end up resulting in the end manifestations, such as depression or hypertension and whatnot. But again, you have to go even further back. And so you see that, in fact, your health behaviors are a combination of the health system, the education system, infrastructure in the community, what's going on with the environment and whatnot. And then if you go back even further to the distal health determinants, what we're seeing is that these are being grounded in a combination of colonialism and counter-mirrored by self-determination and this drive for us to be able to be in control of our own communities, our own health. The last aspect that I want to talk about was intersectionality and how important it is when we're thinking about Indigenous people and our health. And that is this layering of resilient and stress factors. And so, on a positive side, we have indigeneity as a really positive identity, self-determination, our relationships, connections with each other, with our past and so on, cultural connectivity. But on the flip side, we're struggling with such things as racism and colonialism, residential schools, now poor socioeconomic status, poor housing. When you think about COVID and its impact within Indigenous communities, a lot of that is going back to overcrowding and poor housing, right? Food insecurity, the disconnection and disruption that we have experienced. And so all of these things are interlayered, and I think that what this is pointing to is that these are complex situations resulting in a variety of problems that then will take complex solutions. And the solutions have to deal with a number of things on a number of fronts. As well, I think it's really important when one is thinking about such things as racism or gender, that one takes a very strong intersectional lens or approach to it, so that one is recognizing that the racism, let's say, that is experienced by Indigenous people may be different in terms of quality and intention than racism that is experienced by others. So I'm not saying that one is worse than another, but definitely that there are differences in what the experience is and what the intention is behind it. Same with gender and so on. And so we tend to use a very strong intersectional lens in our work.
So now we'd like to turn to ethical engagement, and the next two slides will illustrate two very important concepts in this. The first is the concept of ethical space, and you may be familiar with this. It was put forward by Willie Ermine, who's from Saskatchewan, from Sturgeon Lake First Nation. Willie is not only a professor, but also an elder and a lodge keeper in his community. And he talked about groups getting together who had different worldviews. And in the simplified version, there's a Western group with Western worldviews and an Indigenous group with Indigenous worldviews. And you've already heard some of the differences that exist. And as part of the engagement, and a really critical part of it, these groups need to come together in a equal footing, in a respectful way, where they each recognize the value of each other's views, as in that two-row wampum belt model, and they find ethical space between them where they can then move forward together. The other concept, and it looks a bit similar in these diagrams, and we've talked about this before, two-eyed seeing, up to a monk in Mi'kmaq. It was put forward, this version, by Mi'kmaq elder Albert Marshall. And it states simply to see from one eye with the strengths of Indigenous ways of knowing, and to see from the other eye with the strengths of Western ways of knowing, and to use both of these eyes together. This is really a similar statement to what we had in that Treaty 6 medicine chest clause that we talked about earlier, and also the recommendations and the calls to action from our royal commissions, that there is a great deal of value to be gained by using both Western and Indigenous ways of knowing in working on issues in Indigenous health and many other areas. The other aspects of Indigenous ethical engagement. So in Canada, we have policies set out by our research granting councils. So this includes not only the health research councils, but also engineering, natural science, arts and humanities, social sciences. And there's a chapter, I think there are 13 chapters altogether in the latest version. And chapter 9 deals with research involving First Nations, Inuit, and Métis peoples of Canada. And there are a number of concepts on this slide and the next one. And I've bolded what to me are the most important ones. And the first one here is the requirement of community engagement in Aboriginal research. And that also then relates to the ethical space that we just talked about. But this is really an ethical requirement. You can't do ethical research with First Nations, Inuit, or Métis unless you engage with them, and that's very important. The principles continue here, and again, I've bolded two that I think are really important. One maybe is similar to the previous one, collaborative research. Not only do we need to engage with communities, communities need to be partners in that research. And this can be partners, and really ideally will be partners in all aspects of research, not just in the initial engagement, but in the carrying out of it and the knowledge dissemination. And then there should be mutual benefits. We as academics see benefits in research. It's our stock and trade. We get publications and research grants, but the communities need benefits. They need capacity strengthening. They need to be able to advance and learn in carrying out research by and for themselves, research capacity. So there's a number of other resources which we put here in web links, and they will be available to everyone after this, but I will mention the top one. So the Tri-Council policy statement actually followed what initially the Canadian Institutes of Health Research did, where we developed guidelines for health research. And these were in effect for a period of 3 years until they were superseded by the Tri-Council policy statement. But they're much stronger than that because they also give good examples, working examples of how research can be engaged. And Alexandra and I are part of a group that's listed in the next links on bringing back these guidelines and actually using them more as a practical guide to health research with Indigenous peoples. So now we go on to moving forward, and we're getting near the end of our talk.
Yes, sorry, I just wanted to go back to the previous slide. And the bottom link is actually a training resource that has been developed based on the manuscript that we wrote, which in turn is reflecting back to the CIHR guidelines. And so these three are all interconnected. The bottom one being the training resource is an open source or open access training resource available to everybody. So I just wanted to highlight that one. Okay, so if we want to go on. So we're now at the point where there's a lot of buzzwords that are going on, things like decolonization, reconciliation, indigenization, and I think that we have to really be thinking quite seriously about what these words mean and how do we operationalize them in our research, in our interactions with each other, as well as with our community partners. And so when one thinks about decolonization, I have here a quote that it must address the hegemonic basis of society's values, practices, and institutions. And so one of the things that we have in Canada, and I would suggest that perhaps the US is very similar, a lot of our research institutions and research funding policies, research funding agencies are all reinforcing the status quo, the colonial system. And therefore, what we have to be doing is thinking of how we can work in new and different ways, innovative partnerships and so on, that help to level the playing field, that help to recognize that, yes, our community partners may need some capacity strengthening in research, but also we as researchers need capacity strengthening in working with communities in a very ethical and collaborative way, in understanding Indigenous ways, and really in going through our own process of decolonization. And so, you know, as we are thinking about our research, one of the things that we always fight against is using terms like marginalization or marginalized people, and instead recognizing these as oppression, you know, the forces that are working against Indigenous people. And therefore, I think that also helps to put you into more of a strengths-based approach and recognizing the resilience of Indigenous people. Colonialism, colonization, whiteness, privilege, thinking about how these things are intertwined and are inherent in our structures and our processes, and how then do you make the invisible visible as part of your research. And I think that a lot of when we're thinking about Indigenous health, we have to transcend the health disciplines and even institutions. So going back to the notion that our health is determined by much more than an interaction with a doctor or the medical system, but rather with housing, with the education system, with the legal system, so many other things. And so a lot of our health research actually has to be very transdisciplinary and really extend the notion of health into more of one, that of wellness, that how are we uplifting and really supporting Indigenous people to achieve their notions of health and wellness. Sorry, I'm trying to move the slide forward.
No, too far. There we are.
The other thing that I want to talk about quickly are Indigenous research methodologies. And
excuse me.
These are things that we're seeing an entirely new paradigm coming out, that there is recognition that Indigenous health research is a very broad community, very broad undertaking. And sometimes we might be looking at things like asthma and taking a very biomedical Western approach, and therefore Western research tools and methodologies are appropriate and work. However, if we're talking about Indigenous ways of knowing and spirituality and ceremony, then in fact, a lot of our ways do not research methods and so on that are couched within Western epistemology and axiologies and so on, they're not going to be able to appropriately understand what it is that's going on, nor would they be able to render this information in a way that's understandable to other Indigenous people. And so we're in the process of evolving our own methodologies and know of many other initiatives that are going on throughout the world where Indigenous people are taking our ways of knowing, being, and doing and bringing it into the research enterprise. This means that also we have to be working then on creating ethical spaces, because a lot of times our research teams are in fact a combination of Indigenous and allied researchers. We are wanting to bring some of our results back to the Western world. And so therefore we need these ethical spaces negotiated and renegotiated. And I think part of this is also then recognizing ethical space as a spiritual undertaking as well. It's important that the research methodologies that are in the process of being developed and implemented encompass Indigenous worldviews and our knowledge systems. And we need explicit recognition of the underlying epistemologies and knowledges that, are encompassed therein. And in all of this, I cannot emphasize the importance of Indigenous leadership. And by Indigenous leadership, I do mean Indigenous scholars, but also, our elders, knowledge holders, and other people, community members. We've already highlighted two really important concepts that are in fact put forward by our knowledge holders, being Willie Ermine and Albert Marshall. And so really thinking about how we are uplifting Indigenous ways of knowing, being, and doing.
So this is our last slide, and in a way, it's a summary of a lot of what we've been talking about, but it shows a downward sort of wide road to ill health, illustrated by the brown and green pathway that starts with aspects of colonization, as we've talked about, Indian Act, residential schools, 60 Scoop, and so on. And I have to acknowledge Dr. Donald Warren again, because many of the things that are in this slide, he talked about and developed, and you heard about them, those of you who were on the previous one a month ago. These aspects lead to biologic reactions, stress pathways that lead on to not just physical responses, but emotional and spiritual wounds. And we have to consider them in the holistic view of health. These things then lead to negative coping. And of course, we're all too familiar with drug use and alcohol, but there's also disengagement, the negative coping behavior, and in physical things like metabolic syndrome, which is a precursor of diabetes. And then finally, we have the tragic end manifestations that include addiction, suicide, diabetes, a whole list of things. But not everyone goes on this downward pathway, and there are recoveries that are possible. And if you look in the upper right, you have recovery initiatives that are both Western and Indigenous. You have pharmaceutical and counseling, but you have culture-based healing and land-based healing. And much is being done now to study those, to promote those. We can't leave anyone behind, even if they have gone downhill. But in the middle, you have resilient strategies, connecting with land and culture through ceremony, spirituality, supporting positive identity, as Alexandra talked about earlier, and achieving and maintaining holistic wellness. We hope that this can happen before people go downhill. Our youth are very important in this. And then finally, societal reshaping. We need we need all of our allies, the mainstream as well as ourselves, to deal with health determinants and the reconciliation, the resetting of the relationship. So,
Sorry, can I just?
yeah, Alex will
Yeah.
finish off.
Oh, well, I just wanted to add, I think that one of the things that perhaps this diagram and part of our overall message is that I think how you define a problem also then determines the solutions that you're looking for. And so as an example, in addiction, a lot of times they're seeing this as psychological, they talk about chemical, reshaping and other things. We're talking about opioid or other replacement products and so on. But from an Indigenous perspective, if in fact we're recognizing these as spiritual wounds, then what you would look at to try to help somebody heal and recover is going to be very different. You are going to be turning to things such as ceremony and land and culture and, reconnecting with family and community. And so I think that part of how we're defining issues and so on, if we're taking more of an Indigenous approach, understanding these as spiritual wounds, and then the healing, the approach to healing that would be required is going to be very different. And that's where I think, yet again, we're bringing forward Indigenous ways and realizing some of the potential that they have. And that's similar to, let's say, the field of health promotion, where, they're talking about how we have to all be, eat better, more active, all of these good things in life that we know that we should be doing. Also, we need to take care and nurture our spirits, and that will also be protective and have many downstream positive impacts as we go forward.
Okay. I'll stop sharing now, and thank you very much, Miigwech.
Well, what a fabulous overview and orientation.
He's on mute.
Sorry, Joseph, you're on mute.
Yes, I think hopefully you can hear me. Thank you very much for that fabulous overview and deep orientation to so many complicated and important issues facing our communities. So what we're going to do next is move into audience exchange, Q&A, or comments. And so if you have a question or comment for the Kings, please enter it into the Q&A portion of Zoom, and we'll take what we can in the next 25 minutes or so. Just to kick us off, let me say that one domain of expertise, Dr. Alexandra, that you've carefully cultivated lies in these Indigenous philosophies, knowledges, research methodologies. And I suppose if one is thinking about reconciliation and the way that's been talked about up in Canada in particular, you can't get much more reconciliatory perhaps than a two-wide seeing approach that you've helped to unpack for us, and that's circulating much more widely these days. We have a question from someone who asked the following regarding Indigenous ways of knowing. What are the best arguments to justify its application when talking with scientists who may express more reluctance or skepticism? I wonder what thoughts you have in response to scientific skepticism about observing, respecting, and incorporating Indigenous ways of knowing.
Okay.
Go ahead.
Let me start off by saying, just in reference to that last diagram, and actually in reference to Donald Warren's presentation of a month ago, there's skepticism that stresses that relate to racism, that relate to colonization, can lead to ill health. It really needs to be addressed by this idea that health is multidimensional, and that it's not just physical stresses and physical health issues that result, but also mental, emotional, and spiritual wounds that lead, as Alexandra just talked about, to health issues, and that the so there's a good biological base. I mean, this is epigenetics and so on, which I think most mainstream scientists actually fully accept and believe in. So it's not mumbo jumbo. It is science, and as Alexandra just pointed out, if part of the issue is a spiritual wound, then you need to deal with the spiritual wound, not just the physical wound.
I also think that it helps to be bringing together a variety of perspectives, including Indigenous knowledge holders, because we can start to unpack and appreciate the gifts that Western science bring, but also recognizing that this is a relatively young and immature field. You look at Indigenous knowledge systems and they go back tens of thousands of years, and so a lot of times what I find is if we can take something that is not contentious, not the thing of relevance, and have a discussion about how does Western ways understand it versus Indigenous ways, it helps to open people's eyes to the fact that the limitations of Western ways of, let's say, trying to express yourself in English, and other things. And so if you can get some buy-in about an issue that is not particularly under contention, or I think it helps to bring people along to the fact that now that we're going to talk about this research question, what are other ways and so on. So trying to introduce it a bit more gently and gradually, if you will.
Wonderful advice. Thank you. Here we have another question. This is more of a request for clarification. Could you briefly elaborate on the use of strength-based language and clarify the appropriate use of the terms marginalized versus oppressed?
Okay, so as an example, I have the privilege of doing research with a group of people who live in the downtown east side of Vancouver. And so for those who don't know this name, it is like many core neighborhoods, inner city neighborhoods in our big cities. And at least in many of the Canadian contexts, cities in the Canadian context, there is overrepresentation of Indigenous people in these environments. And so a lot of times when you're reading research about people who live in the downtown east side, they talk about people who are marginalized, that have all of these challenges and so on, but also that are reliant on such things as food banks and a variety of social services. Okay. Anyhow, and so one of the things that I do is that as I'm talking with our community partners, with participants, I am absolutely amazed at hearing the challenges, the struggles, the trauma that they're going through, and thinking about, first of all, how incredibly strong they are as people to be able to go through these things and come out the other side as well as they are, but also the notion of resilience. And I'm thinking about resilience in terms of if something happens and it causes you to fall back, that in fact, they're able to pick themselves up and come back, maybe not to where they were, maybe further ahead, but how much ground that they're able to regain. I also think of resilience rather than on an individual level, at a community level. And as you listen to people who are in these environments, let's say, they are talking about a community that is there, and they recognize this as chosen family, as relationships that really matter to them. And there's also this notion of trauma wisdom. And so this is where, in fact, you're going through something, and having gone through it, you're able to not only heal and perhaps recover from it, but even learn from this and it becomes a strength for you going forward. It's part of who you are and makes you a better person as a consequence. And so I think that when I'm hearing people talking about, marginal people and so on, it's like, no, they're not marginal people. These are incredibly strong, incredibly resilient people, and that they're constantly, being brought against with forces of oppression, that they're doing their best to either navigate, their way through it or move beyond it and so on. And I sort of picked one of the more extreme examples in talking about, let's say, the downtown east side. But the reality is that for people Indigenous people who are living, let's say, in First Nation communities or on reserve, or our Métis brothers and sisters, they also have multiple forms of oppression that they're constantly having to challenge and, somehow make their way around or through. And so again, just thinking about the strengths and resilience of people. And so as an example, in terms of language, I recently wrote a grant where I highlight that from an Indigenous perspective, women in our community were the leaders, our matriarchs, our keepers and nurturers of the next generation. And so then can we think about that in terms of where we are right now in the downtown east side and how we can help support our sisters to be those women that our ancestors knew were following and become the mothers and leaders that we need for the communities going forward.
Well, thank you. That concrete illustration is very helpful, I think. And here's a request for another concrete illustration. Could you share some examples of research or health delivery projects going on that are incorporating Indigenous knowledge systems equally with Western methods?
Okay, I'll start and then we'll see if Malcolm wants to chime in. So we have one project that's going on right now, and we've been very, very fortunate. And again, I think that relationships take time, trust takes time. And so this one group I've had the pleasure of working with for about 5 years now, and it includes researchers that come from the perspective, the expertise of lived experience. And so some of them have been in the downtown east side, have experienced homelessness, have been involved with the sex trade, various other things. And so when they're telling me that these are the research priorities, these are the kinds of questions we should be asking. You shouldn't be asking those questions because they're going to be re-traumatizing the participants, and so on. They have been able to impact the research in such amazing ways. We also have an Indigenous elder, First Nations elder, who's been part of this research. And she and I and this other person have been working on what we call ceremonial research. And so, Sean Wilson, as an example, published his book, Research is Ceremony. We're actually thinking ceremony is research. And so with this knowledge holder, an elder, she brings people into ceremony, and it is in that space that we are now undertaking research. And the results are just so incredibly rich. And what we realized is that whether you're looking at narrative inquiry or grounded theory, none of these tools really help to understand the spiritual messages that are being conveyed and the healing that is happening. And so now we have started into what we're calling a sacred coding project. And so we're trying to look at this very much from an Indigenous way of knowing, but really highlighting spiritual aspects that come out in the research. As well, the peer researcher that I mentioned earlier, we tend to find that she has more of an intuitive understanding of things. And so she will be, let's say, reading through a transcript, and it could be, a paragraph, it could be 15 pages, and she puts it down, she says, that's self-harm. And it's like, nowhere does the person necessarily mention self-harm, but she recognizes what the person is going through, what their emotional responses are, the behaviors and whatnot. And so what I find is that this is again highlighting that an empirical approach to research, thinking that we as the researchers are objective and uninvolved and do not have lenses and so on, I think is really important to, in fact, be bringing our lenses forward and recognizing them and understanding what strengths they can bring to the research product. Do you want to add anything?
Well, something rather different, but I think it also addresses it. So we have a colleague who works on Six Nations Reserve in Ontario named Karen Hill. She's a family physician and she works with traditional healers in her primary health practice. And she and another colleague, Bernice Downey of McMaster, are doing research on this clinic that they call Judda's Place and how it works. And you know, so I think there are other examples where people are bringing both Western and traditional ways of knowing and doing together. But I just thought I'd mention that one.
Thank you. Great examples again that help to illustrate some of these important points. Here's another question, I think around maybe the concept of decolonization. I noticed the concept of decolonization's musts did not include rematriation of lands and sovereignty. How does their inclusion exclusion affect research practices?
That's a big one.
So maybe I could start off. Repatriation of, that would be, I guess, in a way, an ideal, but can we ever get there? I mean, I think the important and perhaps main step is at least a return, and this is more the reconciliation, a return to the mutual respect that we had in Goswenta, the two-row wampum belt, the ethical space that Willie Ermine talks about, where Indigenous ways of knowing and doing are valued, and that would take us part way there. Will we ever totally decolonize? I don't think so. Not certainly in my lifetime or my grandchildren's lifetime.
I think that what I might add to this is that I feel that we're on a journey, and what we are talking about today is only possible because of the incredible work and insights provided to us by those who came before. And so, as Malcolm says, this is an evolving area. And as we look at, as an example, territorial acknowledgement is now becoming far more commonplace. And at least, in Canada, we talk about this treaty or that treaty. The reality is, if you think back to that opening map and what existed before, there weren't treaties, or not treaties as recognized within the Western court systems and so on. There were agreements between Indigenous people, and the lands that flowed and the people that flowed across them. And so does decolonization mean somehow managing to recapture some of that, recognizing that now we have all these borders and systems and other things that have been overlaid on that? So I feel like we're not able to answer that in some ways, and that the answers will be put forward and probably evolved over time.
Fair enough. Thank you. Here's a question for Dr. Malcolm. For 7 years, you directed the Institute of Aboriginal People's Health, now the Institute of Indigenous People's Health. And many of us in the US are deeply envious of the very existence of such an institute within Canada's national research funding portfolio. What have been the major contributions of the Institute to Indigenous health, and what more needs to happen to explain and ultimately remedy Indigenous health inequities?
Okay, go ahead.
So first of all, and I do need to give credit to the first director, Dr. Jeff Redding, was the resurgence, if you like, or a strengthening of research capacity. 20 years ago, Jeff and myself and one other person were, as far as we knew, the only Indigenous professors in health research in Canada. And now we've got literally dozens. That's wonderful. And a lot of this is because of the program focusing on capacity development, strengthening that represented the first decade, if you like, of the Institute. What I share with a lot of people is that period where we brought in the ethics of engagement, and it's not just me. There were many people, including Marlene Brent Castellano, the Mohawk ethicist who led that. We worked hard to get the CIHR to recognize the importance of devoting research resources that reflected Indigenous health and that represented a reasonable proportion of the total resources based on our population. So it's a bit different than the United States. Approximately 5% of Canada identifies as Indigenous, and we made strong arguments that the Canadian Institutes of Health Research needed to devote 5% of its overall budget to Indigenous health. We're very different than the NIH, and in some ways we're envious of NIH because of the huge budgets compared with ours, but we were successful in making those arguments, and it's still a little bit notional. I think maybe we're somewhere between 3 and 4%, not 5%. But this is a huge step, and I'm happy to say I was part of that during my time. And the current director, Dr. Carrie Bourassa, is continuing those efforts.
I would add that one of the things that Carrie has been focused on is trying to level the playing field for community partners. And so, as I was saying, you know, the way that our research institute and funding has sort of unfolded is that it privileges Western institutions. And so then what do we have to do, either within individual projects, but more to the point at more of a macro level, to be ensuring that, let's say one of our community partners could submit their own grant with their own researchers and then, you know, be able to administer this outside of the academic institutions. And so I think that we're moving closer in that direction as well.
Amazing. Let's take one more question here before we wind down today. This is where the rubber meets the road, where, of course, there are not large numbers of Native people involved in high-powered research. So this is what we need to know from this individual. What advice would you have for a medical researcher who's very passionate about working with Indigenous communities, but does not personally identify as a member of the community? Can they curate ethical and responsible research in the same capacity as an Indigenous researcher, or does being an outsider inherently limit the reception and validity of the research?
Take that.
Okay, well, I'm going to start with an answer, and I'm sure Malcolm will kick in. So I think that the notion of ally and allyship is critically important here. And want to point out that in many ways, all of us end up being allies. So as an example, Malcolm and I are currently at the University of Saskatchewan. We are guests and we are actually settlers on Treaty 6 territory in the homeland of the Métis. We walk with our Indigenous brothers and sisters there alongside them as allies and are doing our best to be supporting them. I recognize that my worldview and understanding is very different than theirs, we look for points where there are similarities and ways of understanding and so on, so that I can be a better ally with them. And that allyship is an evolving process. It is an ongoing commitment. There needs to be self-reflexivity. And so therefore, I would strongly encourage everyone to be thinking about how they could be working with local Indigenous people and what that might look like for them. We've had the privilege of working with some very Western biomedical researchers. I'm thinking right now, we're working on this one project that is spinal bulbar muscular atrophy, a very rare genetic disorder. And we have the privilege of working with a neurologist as well as a neurogeneticist. And they are constantly coming to us with humility and recognizing that there are things that they're not understanding about Indigenous ways, about community engagement. And meanwhile, I can assure you, I really have very little understanding of some of the complexities of the genetics or neurology to this. And so again, with we're taking this two-eyed seeing approach, we're embracing each other in creating this ethical space, and frankly, it's for the benefit of those Indigenous people who are living with or affected by SBMA or Kennedy's disease. You want to say anything?
No, I think you said it all.
Okay. Well, in that respect, I'll take one more question. We'll key up an easy one here since we're winding down. This person writes, I have seen arguments that sharing Indigenous knowledge can be exploitative. Western science picks and chooses what they want to see and discards the rest for their own benefit. I'm just curious if y'all have encountered this line of thinking and what your thoughts on it are.
Sure. Well, actually, Alex has this onion analogy, and maybe I let her.
Okay, so I think we always have to be very careful about exploitation and appropriation, because that really has been a hallmark of research about Indigenous people historically. And so we're really guided by a variety of our ethics documents, the Truth and Reconciliation Commission, and United Nations Declaration on the Rights of Indigenous People. And that is that Indigenous people have to derive benefit. They have to be the ones who are helping to prioritize the research agenda and determine what we're going to be working on and how those results are going to be disseminated. And so Malcolm mentioned my onion, which is, I just think about an onion having all of these layers. And so what we decide to disseminate to the mainstream may in fact just be the outermost layer of an onion. What the community may decide that they want other Indigenous people to know, maybe a few layers further in. What they decide that they want their community to know might be even deeper within the onion. The absolute core, the foundations of this knowledge, the reality is that that is held by one or more knowledge holders who have the responsibility of transmitting that knowledge forward, and it's up to them to make those decisions. So again, really respecting autonomy, self-determination as part of the research undertaking.
Very well said. Thank you so much. So we will move to close here now. I can't express my gratitude enough. This has been fantastic. I wish we had an extra half an hour, or maybe we'll have to have you back sometime soon. But thank you so very much for these insightful and important reflections. I should say to the gathered folks that this concludes our Harvard University Native American Program Global Health and Social Medicine joint sponsored Indigenous Health Seminars for this academic year. We do intend to resume again in the fall, but of course, because we don't exactly know yet how COVID's playing out and whether we'll be able to gather in person or not, we'll have to wait and see what shape it will take, whether it will be continued virtual in this sense, or whether we can do the dinner gatherings that we'd originally imagined. But I should also let you know that the talks that we've had so far just to launch this in this semester, I will circulate links to the uploaded recordings to the same folks I circulated all this to before, so that you all can access the recordings online and you can circulate those around. That way we can make sure that lots of folks who couldn't be at any one of these on a given day can still benefit from so much wisdom and insight. So on that note, thanks again, Dr. Alexandra, Dr. Malcolm King, and this concludes our program for today. Best wishes all, and stay warm, be safe.